Thank you.
Cool. Alrighty. Good afternoon, everyone. So my name is Courtney Ierano, and I'll be presenting with Jaclyn Bishop. We're both PhDs with NCAS and also pharmacists. I was meant to talk a bit earlier and give an overview of what stewardship was, but I feel like we might be a little bit past that now, so I'll skip a couple slides. But at NCAS, I just want to highlight some of the key aims. So within the research group, we're looking at understanding current prescribing behaviour, and by doing that, we're able to then hopefully develop, implement and evaluate practical strategies that are useful across Australia. And the bottom point there, which I thought was really important, is that we want to effectively translate our research findings and then influence policy and current practice. So we've heard a lot from the animal stream. So NCAS adopts a One Health approach. So we have a lot of PhDs, postdocs, master's students looking at a range of elements of stewardship. So as you heard, the animal stream looking at companion animals, equine health and livestock. And then across human health, I'm looking at surgical prophylaxis in the tertiary centre. Jaclyn will talk about rural regional health. We're presenting from general practice, community pharmacy, aged care, role of nursing and any fungal stewardship. So a range of things that are covered that all then have their own issues with stewardship and how that's implemented in their unique settings. So AMS across the healthcare system for humans is quite well set up when we compare it to our animal health counterparts. So a big resource that was recently updated last year was the Antimicrobial Stewardship in Australian Healthcare, and it gives good guidance to what is required for an AMS service. Obviously, this is more targeted to the hospital setting. And then following on from that, there's also implementation toolkits. So in comparison to what our animal stream have talked about, there's a lot more things going on with human health. But of course, it still comes down to implementation. And I've just put there that a key point that the implementation of guidelines, our AMS programs and the resources are just as important as the quality of the original content. I'll talk a bit more about my PhD research. So I'm looking at optimising antibiotic use for surgical prophylaxis. So one of the first things that I did was I evaluated the implementability of the antibiotic surgical prophylaxis guidelines. So the way I did that was with the Guideline Implementability Appraisal Instrument, also known as GLIA. We had 10 participants respond to the appraisal tool, and basically it helped identify facilitators or enablers and barriers. And from that, we were then able to develop some meaningful recommendations to support those facilitators and address the barriers. So in the pink text, it's essentially what the key elements of guideline implementability and what's needed. So one facilitator was measurability. People like guidelines that enable things to be measured. So auditing, such as the Surgical National Antibiotic Prescribing Survey, is really helpful for that. And then flexibility. People like flexibility in their guidelines because every patient is unique, and a lot of surgeons don't think that the guidelines are always applicable to their patients. So allowing for flexibility to those guidelines was considered a major facilitator for guideline uptake. In terms of barriers, there was a lot of issues with engagement with the surgical craft groups, and also query or a lack of transparency and linkage of evidence to the guideline recommendations. Also a lack of implementation resources and tools, and a need for ongoing further guideline appraisal. So this is just the initial appraisal, and then since we've done this, the guidelines were recently updated in April. So we're suggesting that it be done again to see if there's any difference. My second project looked at measuring appropriateness of current antibiotic prophylaxis practices. So using the surgical NAPS data set, we had over 2,000 surgical episodes across Australia captured within this data set, and basically identified key areas to target for any antimicrobial stewardship interventions. So high rates of inappropriateness was documented for both procedural and post-procedural prophylaxis doses and across all surgical craft groups. And then the reason for inappropriateness then varied based on the craft group and the type of prophylaxis. So therefore, it's highlighting that even within my stream of research, surgical prophylaxis, you can't create an AMS intervention and then just apply it to all surgical craft groups. All surgical craft groups had their unique issues and problems with surgical prophylaxis prescribing. And then therefore, by using this information, hopefully will lead to the development of more tailored AMS interventions. My last project I'll talk about is a large qualitative work that I've done, exploratory multi-site collective qualitative case study, where we conducted focus groups and semi-structured interviews with a range of surgical craft groups, anaesthetists, theatre nurses and pharmacists, basically trying to get a greater understanding of the decision-making behind surgical prophylaxis prescribing. So we had large audit data telling us what's currently happening in Australia. We've got an implementability appraisal of the current guidelines. This qualitative study was trying to understand what factors were informing or driving current behaviour. And to do that, I used two theoretical frameworks, the theoretical domains framework, the TDF, and then the COM-B wheel. So by doing that, it led me to develop this framework of 6 overall themes that then had sub-themes that were then mapped to the COM-B and the TDF. Using a theoretical framework helps helped generate a greater understanding of behaviour and behaviour change. It provided structure to my analysis because after 15 focus groups, there's a lot of content to go through. So it helped me categorise these themes in a more meaningful way. And it helped identify these sub-themes as enablers or barriers and identifying which are gaps to current, or implementation gaps to current prescribing decision-making. So in summary, surgical prophylaxis and stewardship is quite complex. No surprises there. There's multiple stakeholders involved, but one of them being surgeons, and we definitely need to get them more engaged in this area. So we can throw them guidelines and directives, but at the end of the day, we need to know a bit more about their reasoning and their decision-making to help change their behaviour. There's large hierarchical influence. So the approach of targeting junior surgeons is not as effective, considering that what they do is largely driven by what their consultants tell them. There's a lot of fear-driven prescribing. So one thing that came out in the focus groups is, yes, they want to know about the appropriateness of prescribing, but they want to know what happens to their patients. They want outcome data. That's more meaningful to them. And if we can prove that by prescribing appropriately and less often, so shortening the duration of prophylaxis and there's no harm done, that is a more meaningful message to them. Throughout the focus groups, we also identified that there's a lot of passive prescribing, so prescribing from anaesthetists and junior surgeons on behalf of what they think the consultant wants, whereas in reality, the consultant isn't actually sure what their junior surgeons are prescribing on their behalf. So there's a need for developing a better model or pathway where the roles and responsibility for prescribing and ceasing antimicrobials is well established. Timing and duration are common areas of inappropriateness as identified from our audit data, and they are potential targets. And as I said, different craft groups have different issues, so we need to factor that in when we want to implement and design an antimicrobial stewardship intervention. And as well, it's not just the surgeons. So anaesthetists have a role in the administration and sometimes make the decision for antimicrobial prophylaxis, and pharmacists and nurses have a limited role, but there's definitely room for building capacity and how they influence surgical prophylaxis prescribing. Now with that, I'll invite Jaclyn to come up and she'll talk about AMS for regional and rural health.
Can I just say quickly?
Yeah.
Structure steps and use the models and frameworks and so on.
Thank you.
I just have one question.
Yeah.
You said something about customisation or tailoring. kind of for the different groups and needs and so on, acceptability? I mean, what would that look like?
So
What do you mean by that?
with the surgical maps, like it's an online auditing platform, and when they're assessing the appropriateness, they can put, so if the prescription was inappropriate, they can say why that prescription was inappropriate. So did it have something to do with the timing, the duration? Was there a contraindication with the patient's allergy or the lab results? Was the dosing incorrect? So based on that data, the most common was timing for the preoperative doses and duration for postoperative. So they can then become informed targets. Another example might be that one surgical craft group was using a lot of the antimicrobial choice, so broad spectrum antimicrobial. So that then, instead of focusing on timing for that unit, it might be they're using a lot of kephrax and a broad spectrum antimicrobial that's not indicated. So then we can then look at why that might be prescribed. Is there any reasoning for that? Is it like appropriate in any other way? And then, of course, then we have to engage with the actual unit themselves to then generate change. But in terms of targets, we generally go off those reasons for inappropriateness. Does that sort of give some sort of clarity to that?
A little bit. I thought you were sort of suggesting that then the sort of implementation strategies would be tailored.
Oh, I mean, I guess that then is true, because then it's what craft groups are you, like what's unique to that craft group, like. But I guess the most craft groups are quite hierarchical. But
so I'm open. Training would be tailored, prompting.
Well, it would depend on what the intervention was.
Has to be addressed at a regulatory level. The college taking on board this information, which is not really out there yet. The individual surgical groups taking on board, and at the hospital level and private, it's just so.
And then public and private is hospitals is another issue. And then even though there's the College of Surgeons, a lot of the specialty groups have their own schools or groups, and they don't really feel that the College of Surgeons speak for them. So there's a whole lot of other issues going on there. So thank you. Oh, sorry, Jaclyn.
Thank you. So there's a lot of data out there that shows there's health inequalities for people that live in regional and rural Australia. The Australian Atlas of Healthcare Variation highlights that quite clearly. And if anyone was watching the Four Corners program called Health Hazard, that highlighted some catastrophic events that happened in rural hospitals, it was really quite frightening, some of the events that were happening. But in terms of AMS, what sort of data do we have about whether there are AMS inequalities in those hospitals? We do have some evidence that the uptake of AMS program and elements is less in rural hospitals than it is in metropolitan hospitals. So for example, there was a survey that was done in 2017, which included Victorian hospitals, and 63% of them said that they had no funded AMS position. So there is some data there that suggests that there is some inequalities. But really, there's no data on whether there's any differences in patient outcomes as a result of these inequalities. So in terms of the journey that I've gone through as part of my PhD, the first thing I looked at was the different models for antimicrobial stewardship programs that were published throughout the world, I suppose, and most of the programs came from the US and Canada. So the types of programs that were being implemented in those countries: hub and spoke models, networked models, telehealth models, fly-in, fly-out type models for infectious diseases expertise. So there were some learnings that could come from those different programs in different countries. But of course, there's differences in the health systems, how the health systems are funded and structured, that need to be taken into account. The second project was having a look at the National Antimicrobial Prescribing Survey NAPS data to see whether there were any differences or similarities in antimicrobial prescribing between regional or rural hospitals and major city hospitals. And through that piece of work, we were able to identify that there were some conditions and some antibiotics where there were negative differences between prescribing. And cellulitis was one particular condition that came out of that analysis, which feeds into Project 5. But also some high-risk conditions such as sepsis, and there's work that's been being undertaken by CAS and others to implement a sepsis project throughout regional and rural hospitals, which has had some really positive results. Project 3 and Project 4 were qualitative studies, and they were trying to look at what are the barriers and the facilitators that exist in the coalface clinicians that are doing AMS day-to-day in regional hospitals. We know that AMS is part of accreditation, but why are they still struggling to have effective programs in place? And Project 4 was key informant interview. So looking at really the people that were driving AMS at a more national level or had been involved in some form of innovation, what were their thoughts on how AMS could and should be implemented in regional hospitals? And then Project 5 is the cellulitis bundle of care that I will speak about shortly. So through that work, and particularly the focus groups and key informant interviews, it really made it very clear that AMS programs in regional or rural hospitals is a balancing act. You've got the drivers that do apply for everyone around accreditation, the clinical care standard, the national strategy, and your passionate champions that are within these organisations. But there are a number of things that do make it challenging. Access to resources, so that's both specialist resources to be able to consult on more complex conditions, but also just the bodies on the ground. So a lot of rural hospitals don't have an on-site pharmacy, and therefore you can't rely on pharmacists to be driving your antimicrobial stewardship program when they're there or they're in such a limited resource. Distance was certainly highlighted, so the further you are away from perhaps your pathology provider can impact on how long it takes you to get your therapeutic drug monitoring back, which then influences your choice on whether you choose that drug that needs therapeutic drug monitoring compared to another. The culture of independence certainly came up with clinicians that are used to working very independently in their rural hospitals because they've had to. There isn't someone else traditionally been there to ask, so they're used to making their own decisions. Context is very important, so resistance to antimicrobials does vary depending on your location, so whoever's providing the advice to those hospitals needs to understand that. Relationships being both positively and negatively impacting in a small environment can obviously help with influencing people's practices, but also can make it difficult to have challenging conversations if that person is someone that you see down the street on a Saturday morning. And then benchmarking, how do you know that these smaller hospitals in rural areas are going okay compared to their counterparts, and expressing difficulty in finding those like hospitals to benchmark with. So Project 5, as I mentioned, was driven out of the NAPS data, highlighted that cellulitis is a particular area of concern where antibiotic prescribing was less optimal in regional hospitals than in major city hospitals, but also it's a very common condition that would hopefully be something they're seeing very frequently and have meaning for them to want to improve their practice. So the research question that was proposed was, can a cellulitis bundle of care improve appropriateness of antibiotic prescribing for cellulitis? And it is a multi-site before and after study. So we've got 3 hospitals in the Western District of Victoria involved. So Ballarat Health Services, where I currently work, Colac Area Health, which is about an hour from Ballarat, and Wimmera Healthcare Group, essentially Horsham Hospital, which is about a 2-hour drive from Ballarat. The bundle of care itself is something that we've had to design as part of this process. So I'm sure you can't see any of the detail up there, but on the your left-hand side, there's the tool that we've developed, which takes the clinicians essentially through the bundle elements that we think are important for cellulitis. So making sure that you've got the right diagnoses and that you've considered differential diagnoses, that you've evaluated the severity and you've really ruled out patients that have something more complex that you would need to seek some expert advice and not follow a tool such as this. Helping them to decide the location of care and their antibiotic choice that's important relative to that location of care. Making it very clear what some of their care requirements are for the patient. So limb elevation, so we've done quite a lot of auditing so far and it's very poorly documented whether the patient's limb was being elevated, but in fairness to the nursing staff who are implementing that, where was it ever said that that was what the doctors required for that particular patient? So making that explicit so that it can be followed. Looking for predisposing factors, really important to make sure that the cellulitis can resolve, but also that it doesn't reoccur. Oral switch, so trying to encourage that to occur frequently, so on a daily basis. So the subsequent pages of this tool have a daily checklist essentially to go through, and also treatment duration review. So trying to keep track of how long someone's been on the IV, then they go to oral, but how long is that treatment duration to make sure that the courses aren't being excessive. And then on the other side is the cellulitis leaflet that we've produced. And the idea of that was for it to be a bit more of a pictorial representation of what a patient might expect while they're in hospital. And then on the flip side, we've got some self-management strategies for them to do while they're at home, which are actually quite similar to the ones that happen while they're in hospital, but just sort of changing the language a little bit for them to be drivers of that. So they're really the two things that we're going to implement as part of this, this project. So I suppose thinking about the things that we've learned through the work that we've done earlier, the focus groups, key informant interviews, but also other people's work as well, there were probably some things that I thought might need to be considered for this implementation. And I thought that I'd just reflect at this stage. We haven't implemented the tools yet. They're still in the co-design stage, but we're hoping to implement in early 2020. I thought I'd reflect on whether I think these are problems and whether if I've been affected by those so far. So evidence not generated in the rural setting can always be an issue with implementation. Well, you did that in a city hospital, that doesn't apply to us, or that's not our patient group. And we thought this was probably going to be unlikely given that the NAPS data did show that cellulitis is a common condition for rural hospitals, but also that there's a potential issue that could be addressed at the regional level. And we've had good buy-in. It was quite easy to get the other two sites on board. So it was pretty much, yes, let's do it. So I think that's a really good sign that the evidence is not something they're questioning. Also, the treatment of cellulitis is quite well established. It's been in therapeutic guidelines with not a huge number of changes for a long period of time. So there's evidence that is standard practice that needs to be implemented. Locum and sessional staff is always an issue for rural hospitals. I say potential here because some of the hospitals involved have salaried medical staff that are there routinely. Colac uses GPs, so that's something that we will need to consider. Horsham is more of a salaried medical officer setup. So there are some structural differences that we'll need to take into account. Access to equipment or tests is unlikely to be an issue for cellulitis. There's no specific test that you do for cellulitis, and any of the scans that you do for differential diagnosis are fairly routine. Specific populations with particular needs, often that's referred to perhaps Aboriginal and Torres Strait Islander groups, transient populations such as grey nomads heading north for the winter. Probably unlikely for these particular hospitals given we're in a fairly tight geographic location. Competing priorities has probably been the biggest one so far. Two of the hospitals that we're working with have both undergone accreditation in the last week or the month leading up to it, and it's been a really big barrier with engaging anyone at the sites. It's really, we don't want anything else, we've got to focus on accreditation, and it's probably impacted the co-design process and probably feeling that might come back to influence maybe the uptake because we haven't necessarily been able to engage them as well as we'd like to. Different staffing structures and resources, I've mentioned that. Also the amount of pharmacy at those sites is variable. Outsider syndrome is also something to be considered. I've mentioned about that culture of independence and how willing they'll be to take up the intervention. One thing we did do at the outset was in the grant proposal we put forward, we had funding for research officers at each of those sites. It's not a lot, but it is someone that's there who's asking them the questions about the tool and getting that feedback and bringing it back centrally. So I'm really hoping that will help. And finally, rationalisation of variation comes up in some of the literature as well. That's potential that we have to do something different because our hospital is different to your hospital. It's a potential, but so far that hasn't come up as a particular concern. So I really just wanted to share those insights into the implementation challenges so far. At the moment, I'm working through the REAIM framework for evaluating the implementation of the tool. We certainly had in place our clinical outcomes, if you want to call them those, but really the process now that we've got the tool designed is to work about how we'll know if it actually was used in the way that we intended it to be used. Pretty sure that's it.
So what kind of trial is this? So I think you said it before now.
Yeah, that's right, yeah.
So is it a pilot study? Is it a feasibility trial? Is it an implementation trial? How do you kind of conceive of the staging?
Yeah, I mean, I'd probably classify it as a pilot, but I think the more I've kind of gone through the process, it's certainly about the implementation and potentially looking at how we would scale it up if it was successful. So trying to think through those things at the same time. It's not randomised. It's got a number of names, but it's, in essence, it's a quality improvement project, and it's something that will be rolled out, and we don't have individual patient consent to receive the tool. It's just considered part of practice to deliver that at each of those organisations. So we'll put it in the pilot category at this stage, because that tool, as I said, we've developed ourselves, and it's something we need to test itself.
It's a plan to act study.
Yeah.
You do it simultaneously at all three sites.
Yes.
So you have the first bit of data, reevaluate, and you might modify it.
Yeah. Been thinking through that today. Yeah.
First stage of
Yes.
plan to act, future plan to act.
Yeah. Whether we'll have time to make changes and reevaluate in the same sites, but yeah, absolutely.
It's a feasibility for the first stage of the plan to act.
Yeah.
That's what it is.
Yeah.
There's lots of, I actually answer a lot of the things that you asked, right? But I think one really important thing that Jaclyn's talking is that it's co-designed, and that's the failure. Oh, so often an idea physician writes a guideline and hands it to somebody who has to do this. And what Jaclyn's really done very well is brought together with lots of different stakeholders and got them helping to co-design this thing. So they have a strong sense of ownership. So I think she is looking at the implementability, and then she's also looking at the impact.
Yes, I think that's great, because it also means then that although you're doing this sort of pilot feasibility stage, you've got processing. Once you get to the end of that, you're going to have the learnings and the findings from that, which can then be incorporated into modification, further adaptation, wider implementation.
Yeah, that's the plan, the dream. Wonderful. All right, thank you.
Thank you, Jaclyn and Courtney. We're running a bit late, so we'll take a 5-minute break for a bit of tea, water, and the toilets are on your right here. And then we'll be back with 2 presentations, one on general practice and one on aged care. Thank you.